Good afternoon, good evening, wherever you are. I'm Dr. Navtika Desai. I'm a board-certified endocrinologist practicing in private practice, Hillsborough, New Jersey. Today I wanted to go over some of the 2022 AACE annual meeting updates that I attended that was in San Diego last week from Tuesday through Sunday. And I just wanted to kind of go over some of the updates that we had on days 1, 2, and 3. So the first update that we received was after a long time on guidelines and management of primary hyperparathyroidism. So the evaluation includes biochemical, measure adjusted total serum calcium, ionized if normal calcemic primary hyperparathyroidism consideration, but serum calcium is just fine, with phosphorus, intact PTH, which should be fasting, and 25-hydroxy vitamin D and creatinine. And in terms of skeletal evaluation for diagnosing hyperparathyroidism, we do 3-site DEXA, lumbar, hip, as well as the distal 1/3 radius. We should order imaging for vertebral fractures, including vertebral fracture assessment, VFA, or vertebral x-rays, and then also trabecular bone score if that is available. And then finally, we want to evaluate for any renal or genetic evaluation for differential for primary hyperparathyroidism. In terms of treatment recommendations, generally we have alendronate and denosumab, which can be used to increase bone density. We also have cinacalcet, which can be used to reduce the serum calcium concentration. And then calcium intake supplementation along with vitamin D, and then estrogen therapy. So the key take-home message here is that parathyroidectomy is an attractive option for asymptomatic hyperparathyroidism. And then cinacalcet lowers parathyroid hormone and calcium often into the normal range. And then non-bisphosphonates and denosumab may provide skeletal protection, and monitoring with annual serum calcium, creatinine clearance, and bone mineral density every 1 to 2 years is advised. So now let's switch topics to a different talk, which was cardiovascular disease in type 2 diabetic patients. We were assessing the risk and prioritizing therapies. This was a very well-attended session. It was great to get the update. But here, this is just a general summary of the treatment options that we have for diabetes, including the later and the newer medications. So starting with the oldest at the top, we have metformin. So although metformin, there remains a paucity of evidence from large, long-term placebo-controlled cardiovascular outcome trials, there's still a substantial interest in potential benefit of metformin for protection against vascular disease. So in general, AACE does recommend after diet exercise to still consider metformin if tolerated. Next is sulfonylureas, which we know that can cause hypoglycemia. However, clearly a risk that could be a cardiovascular disease contributor. So generally speaking, this is regarded as a high risk. Thiodolindaziones within the PPAR family, there is no class effect, and each agent must be considered unique in unique patients. The FDA has mandated that each agent within this class be evaluated individually in a variety of clinical outcome settings. So I will say that the general consensus from the talk from the speaker was that pioglitazone is still a favorable option, especially for those diabetics that have NASH or NAFLD. We usually do not use Avandia generally, but pioglitazone is still an option at a lower dose that was recommended, mainly 15 milligrams, but maybe sometimes even 30. We do not just generally use the higher 45 milligram dose due to edema and water retention and heart failure. The next therapeutic option we have is DPP-4 inhibitors, TZD based on these large cardiovascular trials. Sexagliptin is not recommended in patients with type 2 diabetes and high risk for heart failure. So these are generally indolent. They do not have a lot of side effects. They are still in consideration, but if you'll see the new ACE algorithm that will come out, it will be lower in our protocol. And then the two newer agents, including SGLT2 inhibitors and GLP-1 receptor agonists. So current European and American guidelines support and recommend GLP-1 receptor agonists as well as SGLT2 as first-line therapy in our patients and high risk or established cardiovascular disease. And then in particular, dapagliflozin and empagliflozin in patients with symptomatic heart failure on top of their guideline recommended medical therapies. So keep in mind that the change here is that SGLT2 inhibitors and GLP-1 receptor agonists are used for glycemic control, but they also have an independent indication for patients with established or high risk for cardiovascular disease, independent of A1C lowering. So the key take-home messages from this slide is that there's a growing list of diabetic medications with proven cardiovascular benefit, such as SGLT2 inhibitors and GLP-1 receptor agonists, and these should be generally considered our first-line therapies now for our diabetics with high risk or established cardiovascular. Optimal glycemic control may reflect reduced A1C, low glucose variation, and avoiding obviously hypoglycemia, comprehensive management of all risk factors, including lipid management, blood pressure management, intensive glucose control, and anti-thrombotic therapies should be considered in our diabetics. And pioglitazone is likely beneficial in some instances, and there's a possible benefit also of metformin, as I mentioned, mainly for NAFLD. So continuing on to one of the other topics, ethnic diversity for cardiovascular disease risk in South Asian populations, such as ours in India. So cardiovascular interventions and outcomes. So South Asians, we know, are more likely to have multi-vessel disease requiring CABG versus coronary catheterization. Some studies evaluating cardiovascular events and mortality after isolated CABG showed consistently poorer outcomes in South Asians. So in terms of biological and non-biological mechanisms, there's higher prevalence of insulin resistance, higher fasting insulin levels, impaired glucose tolerance, metabolic syndrome, obesity, dyslipidemia, hypertension, chronic kidney disease in the South Asian population. Unfortunately, there's no other way I could say that. And then dietary habits, smoking, physical activity, social, psychological, and environmental factors also play a big role. So the key take-home message here is that recommendation to use the Q-Risk3 calculator in clinical decisions to reduce cardiovascular risk as early as childhood years. Lp(a) in patients with family history of premature coronary artery disease is recommended, and using an imaging technique such as coronary artery calcium CT is also a good gauge of accurate risk stratification, specifically in the South Asian population. And there's evidence to date that confirms that there's a higher burden of cardiovascular disease in South Asians in the United States as well. So we encourage healthy lifestyle in South Asians and early recognition and treatment of cardiovascular risk factors very aggressively to mitigate this increased cardiovascular burden. So changing topics a little bit, but to still staying on the South Asian population, sex and ethnic differences in risk factors for cardiovascular. So some of the recommendations for South Asians, instead of the normal cardiovascular risk factors that we think about, such as BMI, metabolic syndrome, we want to look at certain other parameters that may be different for South Asians that don't follow the norm BMI cutoffs for a US population. So waist circumference is a big one. So desirable levels in South Asians generally are less than 80 centimeters for women for waist circumference, and then less than 90 centimeters for men. When we look at BMI in the US, a normal BMI is anything less than 25. But in the South Asian population, a BMI of less than 23 in men and women would be considered more optimal. And then in terms of blood pressure, we want blood pressure targets less than 140/80. I still think in our diabetic populations, we want to be a little bit more aggressive, 130/70. Total cholesterol, we aim for those patients at high risk for cardiovascular disease. If they're classified as high risk, we want total cholesterol to be less than 160 and LDL less than 100 if they're high risk. LDL goal of less than 70 in patients with coronary artery disease and or diabetes, and less than 50 if they're very high risk patients. These are the goals for LDL in our South Asian population. In addition, the non-HDL cholesterol goals, less than 130 if they're high risk, less than 100 for anyone with a history of coronary artery disease or diabetes, and then less than 80 for very high risk patients. Triglycerides, the goal is less than 150, HDL goal of greater than 40 in men and greater than 50 in women, and the hemoglobin A1C ideally of less than 6.5. We may accept a little higher A1C goal if you have an elderly population or a population that's higher risk for hypoglycemia. So ACE guidelines show that the A1C should be individualized. And then a lipoprotein A, we want to target a level of less than 20. So the take-home message from this talk was that smaller coronary artery diameter or extraluminal plaque accumulation, similar to transplant vasculopathy, is making the luminal diameter smaller. So this is what we are seeing in our South Asian populations. And they have South Asians have the second highest level of lipoprotein A after African Americans. And this may explain some of the increased risk for cardiovascular disease we see in our ethnic group. So characteristic lipid profiles in South Asians are generally higher triglyceride levels, higher lipoprotein A, increased ratio of apoprotein B to apoprotein A1, smaller HDL size, and increased LDL particle number, and lower levels of HDL, increased CEPT, and pro-inflammatory state. So overall, this is what makes South Asians at a very high risk for cardiovascular disease. So treatment-wise, what can we do is generally recommend low daily consumption of fruits and vegetables. So what we want to do to mitigate this is obviously increase our fruit and vegetable intake, regular exercise, reduce our waist to hip ratio, and then use those new parameters for South Asians versus the US parameters. And then we generally tend to underestimate the cardiovascular risk in South Asians when we just rely on the standard US recommendations. So we should be cognizant of that. Moving on to triglycerides as a factor in residual atherosclerotic cardiovascular risk. And this is also important in our Asian population. And so multiple studies and also the American College of Endocrinology is looking and emphasizes that elevated triglycerides have an independent residual risk for cardiovascular disease. And these are some of the trials that have seen that. And key take-away home message is that advanced lipid measurements are controversial. Treat patients with hypertriglyceridemia to lower their atherosclerotic cardiovascular risk. And hypertriglyceridemia in patients have increased risk for atherosclerotic cardiovascular disease by many mechanisms, not just the typical that we know of, but the risk should be assessed by total triglycerides, non-HDL, and ApoB if that is available. And always encourage diet, lifestyle changes. And then statin still remains our first-line therapy for all these patients. And in collaborating with non-endocrinologists, so there was this big emphasis on an endocrine care team. And so we want to involve a non-endocrinologist in using SGLT2 inhibitors for non-diabetic indications. So we have nurse practitioners, PAs, mainly nephrologists as well, and sometimes even cardiologists. So our endocrine team, when we look at it, includes the patient, the physicians. The physicians could be multi-specialty, endocrinologists, cardiologists, nephrologists, hepatologists, because we now know that diabetes affects multiple organ systems and we need to target them. And then it includes patient navigators, it includes pharmacists, data scientists, and then physician extenders like nurse practitioners and PAs. So basically what we want to do is we want to risk stratify based on health conditions, and then approach patients that are diabetic based on high risk, medium risk, or low risk. And those patients that have the highest risk need this coordination of care. One physician will not be able to manage these high risk patients, so they need to see multiple specialists, have a good collaboration. Low risk patients may be cared for by primary care doctors or primary prevention, and then medium risk patients may need one specialist, etc. So the take-away home message here is that SGLT2 inhibitors are integral in the part management of congestive heart failure, type 2 diabetes with chronic kidney disease. And in order to achieve optimal control for our diabetics, there needs to be a successful collaboration between non-endocrinologists regarding the use of these SGLT2 inhibitors, understanding the indications, the multiple disease states, in order to improve better outcomes. So now let's talk about obesity a little bit. So medical management management, obesity, post-bariatric surgery, and anti-obesity medications. Here on the left, we have FDA-approved chronic weight management medications, including orlistat, which has a lot of side effects and very minimal weight loss. And then we have phentermine topiramate, which is branded as Kissenia. And then we have bupropion, naltrexone, which is branded as Contrave, liraglutide, which is branded as Victoza here in the US, and then semaglutide, which now has two forms, mainly Wegovy is the one for obesity. And then there's a new one that's coming out very soon by Lilly, tirzepatide. And there is another one in the pipeline, which is not FDA approved, which is a human monoclonal antibody that will bind to the activin type 2 receptor. So look out for that. In general, anti-obesity medications are beneficial for addressing weight regain and intermittent weight loss. So therefore, anti-obesity medication should be recommended for prevention and management of weight reduction and intermittent weight loss. When an effective anti-obesity medication is discontinued, we do see from multiple studies that weight will regain and patients will go back on that yo-yo cycle. So in summary, anti-obesity medications initiated after weight regain has been shown to achieve lower cumulative total weight loss. Post-op bariatric patients treated with 2 or more anti-obesity medications have shown greater weight loss. An ideal time to initiate this anti-obesity medication appears to be at post-surgical nadir when weight plateau is reached. Generally speaking, we see that after 7 months or 1 year. Assist patients in optimizing lifestyle modification, including diet, physical activity, and behavioral change. So this is a general guideline in terms of SGLT2 inhibitors and personalizing pharmacotherapy in our type 2 diabetics. So for example, if we look at the data, there's a hazards ratio for heart failure. So SGLT2, the take-home message here is that the hazards ratio is low to the left of the curve, vertical line, if we were to look at this on a graph, showing that all of these decrease the incidence of heart failure and heart failure readmission. So all our diabetic type 2 with chronic kidney disease or with a history of heart failure should be on one of these SGLT2 inhibitors if tolerated. So let's talk about the potential future role of big data, pharmacogenetics, and personalized precision care. So this session focused a lot more on gene therapy, targeted mutations in terms of treating chronic diseases. So there's huge databases of de-identified patient data. Clinicians could enter the patient's characteristics, see from analysis of large number of similar patients how they were treated and what were the outcomes. And then pharmacogenomics, simultaneous impact of multiple mutations in the genome that may determine the patient's response to drug therapy. So this is a big therapeutic target in terms of thyroid cancer, et cetera. Pharmacogenetics, which is the study of genetics causes of individual variations in drug response. And this is where the future is leading, where we're doing gene-targeted therapy to minimize secondary negative outcomes, et cetera. And this is very exciting, and this is the future. And we should be able to see better clinical outcomes. So that ends my talk. Thank you. I hope that you enjoyed it and got something out of it. I encourage all of you to join AACE and attend our meetings. And there is different options for membership. And I hope this was very informative. Thank you again.